Good afternoon. We're starting the public comment section of our meeting. At the onset, I'd like to welcome and thank the public commenters for addressing the committee today. We at the ACIP take seriously your comments and are very interested to hear your opinions. All speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined by a lottery. I want to speak to the commenters, the speakers right now, and say that we have a limited period for public comment, and in order to make it through all of the listed speakers, it is very important that each speaker limit his or her comments to 3 minutes. On your computer screens are a circle that will cycle through 3 colors and at the end tell you that the time is up. We ask you to keep an eye on those on that color cycle. Again, I want to thank the speakers and look forward to your comments. After you approach your time, I will notify you that you have reached the end of your time by saying thank you for your comment. Your time has expired. If you continue to speak for another 15 seconds, you will hear me say, as a courtesy to other speakers, we ask that you conclude your comment. And if you're still speaking 30 seconds after your period of time is over, I will state your comment time has ended. Thank you very much, and your mic will be shut off. So thank you again, and we'll begin now with the first speaker, who is Ms. Sarah Berry. And I'm going to ask the speakers to please announce your name in case I mispronounce it, and please tell us your affiliation. Ms. Berry, please, go forward.
Can you hear me?
I can, thank you.
Okay. Thank you to all members of the ACIP. My name is Sarah Berry, and I am an independent pro-vaccine advocate from Ohio. This is my first time giving a public comment, but not my first time applying. The first time I applied was for the February 2020 meeting, and although I was sad that I wasn't picked, I could hardly predict what was to follow in the coming months, which I now feel very compelled to share. It is important to first warn you of the extensive influence of anti-vaxxers in politics. The anti-vax 501c4 Health Freedom Ohio successfully killed legislation concerning vaccines and is actively in support of bills that would weaken the authority of the Ohio Department of Health. By my estimation, more than half the Republican Party in Ohio is under the influence of anti-vax lobbyists. I wanted to exercise my First Amendment right and give testimony on one of these bills to specifically warn of the influence of these anti-vaxxers. To my surprise, the lobbyists from Health Freedom Ohio responded by attempting to literally censor my testimony from being heard in front of the committee. They were even caught on video bragging amongst themselves about how they, and I quote, worked behind the scenes, unquote, to stop me from testifying. The presence of anti-vax lobbyists is troubling for sure. However, when they have become powerful enough that they try to silence the only person who is criticizing them, I hope we can all agree that a critical point has been reached. So, what next? Well, I think it begins and ends with the portion of my testimony that probably angered the anti-vax lobby more than any other. I genuinely believe that the anti-vaccine community endorses and/or enables the abuse of autistic children. It is because of my efforts that a book teaching parents how to use bleach as an autism cure was removed for sale from Amazon's website. And I have watched in dismay as doctors who administer chelation as an autism treatment gave public comment to this committee. As a layperson, I have found that informing average people of these aspects of the anti-vax community, which I've only begun to touch on, is a much more convincing argument than continuing to parrot the same old sound bites that people have heard before. Yes, I agree that vaccines are safe and effective, but that's a really terrible argument for somebody who doesn't really know anything about vaccines. Health Freedom Ohio could have chosen to try and let me speak, and then they could publicly debunk what I said for everybody to see. Since they decided to try and censor me, it makes me certain that they are unable to defend themselves against my words. And so I will have to keep repeating these words until the day I die, even if I have to get it tattooed on my body. Anti-vaxxers abuse autistic children. Anti-vaxxers abuse autistic children. Anti-vaxxers abuse autistic children. Thank you so much for your time.
Thank you for your comments. Our next speaker is Mrs. Emma Schwartz. Mrs. Schwartz.
Good afternoon. My name is Emma Schwartz, and I'm the president of the Medical Center of the Americas Foundation in El Paso, Texas, and CEO of Bio El Paso Juarez. I have my undergraduate degree from Stanford University and master's in public health from UCLA, both at which I studied pandemics and U.S.-Mexico border health issues. I'm here today to shed light on the situation along the El Paso Juarez border. Although we are two cities sitting across a river and a major geopolitical boundary from each other, we are one community. Our healthcare systems are linked, with many El Pasoans obtaining medical care in Juarez because of the lower cost of care and the high rate of uninsurance in El Paso, and many Juarezans obtain specialty care in El Paso that they cannot find in Juarez. Our cultures are linked, with many of us flowing between our two cities to visit restaurants, access airports, attend school, visit family, and shop. Our economies are tied, with 1 in 4 jobs in El Paso directly linked to the manufacturing industry in Juarez, and we are a major port of entry. As you well know, at this point in the pandemic, our goal is to achieve herd immunity in order to return to our new normal and reestablish our economy. Our experts estimate that if all goes smoothly, El Paso County, with a population of 850,000, will begin to reach herd immunity levels of 70% over the summer and 80 to 90% much more desirable with the emerging variants this fall. We are proud to be one of the cities in the U.S. with the highest percentages of vaccine administration per doses received, and we have a tremendous appetite for the vaccine. We want to achieve herd immunity and are doing our part to get there. However, if you consider our border location, then we must also consider Juarez's population impact on El Paso. Juarez has a population of 1.6 million. In 2018, the El Paso Port of Entry handled northbound border crossing traffic of over 800,000 trucks, more than 12 million cars with 22 million passengers, and more than 7 million pedestrians. In addition, approximately 150,000 U.S. citizens live in the state of Chihuahua, all of whom can access vaccines in El Paso much easier than in the state of Chihuahua, but they're not factored into our population count. It is abundantly clear that we will not reach herd immunity in El Paso on the aforementioned timeline if we are only concentrating on vaccinating the El Paso County population. If the goal is herd immunity, then our border areas must be treated differently than non-border cities. Thus, my request is twofold. First, when allocating vaccines across the country, please consider the U.S. population on the Mexican side of the border and the cross-border movement of people with regards to El Paso's allocation. Second, the manufacturing plants in Juarez have committed to funding $12 million to purchase vaccines for their workforce of 350,000, 40 to 50% of which have comorbidities such as diabetes. If the U.S. government can help them gain access, the manufacturers will purchase and administer the vaccines, but they are not requesting that the vaccine be donated, but they do need assistance in gaining access to the vaccine purchases. These two actions would make a tremendous difference in getting not only our region, but the entire country back to a new normal. Thank you for your critical work that you do, and thank you for your consideration of this matter.
Thank you for your comments. Our next speaker is Mary Izadi. Ms. Izadi.
Forgive me. Hello?
Yes.
Are you able to hear me?
We can hear you very well. Go forward, please.
I appreciate it. Thank you. Good afternoon. I am the Constitutional Policing Advisor for the Sheriff's Department in Orange County, California. First, I would like to thank the ACIP Committee and the CDC for your tireless efforts as it relates to the COVID-19 pandemic. Although I have submitted written comments, my focus today is to request clear direction from the CDC regarding COVID-19 vaccine prioritization for those incarcerated in county jails. The CDC's frequently asked questions recommend vaccinating those who are working and living in corrections environments at the same time. However, unfortunately, there is one oversight in Section 1B of the COVID-19 vaccine allocation program. Phase 1B enumerates corrections officers, but not those incarcerated. That omission has resulted in hurdles for those working directly to promote ethical principles in vaccine distribution and mitigate health inequities regarding vaccine prioritization at county jails. The CDC guidance must state with specificity that those incarcerated are in the 1B category. I recognize the need for flexibility at the local level, but listing corrections employees in 1B while omitting incarcerated persons results in a direct injustice that I wholeheartedly believe this committee did not intend. Without an edit to the current vaccine allocation program to match CDC guidance, state and local governments do not have the clarity needed for an ethical vaccine distribution plan that is consistent with CDC recommendations and constitutional principles. If the CDC recommends corrections officers and those incarcerated should be vaccinated at the same time, then there must be adequate specificity to that effect. 2 days ago, the American Journal of Preventive Medicine published their research on the disproportionate COVID-19 case burden among correctional workers. Their research urged priority vaccination to benefit workers, incarcerated people, and community members alike. Sheriff's departments across the nation have a constitutional duty to care for the well-being of incarcerated persons. The CDC's current guidance and simultaneous vaccinations is consistent with the constitutional mandates under the 8th and 14th Amendments. With one necessary correction, the CDC can rebalance inequity in vaccination distribution. The CDC cannot prioritize those who work in a facility without also prioritizing those who live in that same facility. I recognize there are limited resources and numerous valid competing interests. However, the harsh reality is, with everyone trying to get to the front of the line, there is no financial incentive or political capital earned by prioritizing those who are innocent until proven guilty. In fact, over 75% of the population housed in Orange County jails are pretrial and are not convicted of a crime. Nelson Mandela said, "No one truly knows a nation until one has been inside its jails. A nation should not be judged by how it treats its highest citizens, but its lowest ones." Thank you again for the opportunity to speak to you today and for the invaluable CDC guidance that assists our nation in these unprecedented times.
Thank you very much for those comments. Our next speaker is Miss Nissa Shafi. Ms. Shafi.
Thank you so much. Can you hear me?
I can, thank you.
Okay, thank you so much. Good afternoon. I'm Nisa Shafi, and I will be presenting public comment on behalf of the National Consumers League. For over 120 years, NCL has championed vaccine education and access for consumers who depend on these life-saving medical interventions. We extend our gratitude to the Advisory Committee on Immunization Practices for the opportunity to serve as a voice for consumers. NCL remains committed to educating consumers on the value and safety of immunizations. During the COVID-19 pandemic, immunization rates have dropped drastically, which means that our work is needed more than ever. Even under ordinary circumstances, vaccines are underutilized in adult populations, especially among racial and ethnic minority communities. Health disparities contribute largely to the burden for hepatitis B infections, with Asian Pacific Islanders and non-Hispanic Black communities having the highest rates of HPV-related deaths. Despite vaccine recommendations, there is an estimated prevalence for chronic HPV infection in the U.S. of nearly 1.6 million persons. NCL is concerned that the updated guidance for those over 60 years of age with diabetes getting vaccinated only upon shared decision-making with their providers will not address the health disparities that persist. The populations at risk for Hep B infection are those that are more likely to lack access to health care and not have a primary care medical home. NCL would like to see the CDC support a large-scale education and outreach campaign to raise awareness of the risk of Hep B in older adults and call for increased Hep B screening in high-risk communities across the country. NCL similarly shared its disappointment in response to ACIP's 2019 recommendations for the pneumococcal vaccine PCV13 to be administered for those over 65 years of age with shared decision-making, based on the rationale that childhood vaccinations had dramatically reduced the spread of the disease. However, pneumococcal disease continues to result in an estimated 150,000 hospitalizations per year, and adults over the age of 65 remain at an increased risk. In light of the drop in childhood immunizations induced by the pandemic, the CDC may want to issue caution to providers that herd immunity may have diminished compared to years prior for many of the diseases we target with the most commonly recommended vaccines. As a commitment to our advocacy, NCL continues to reaffirm that vaccines save lives, and we continue to support increased immunizations for preventable diseases. In closing, we encourage ACIP to maintain effective public messaging and strong vaccine recommendations to instill vaccine confidence so that the American public feels safe and informed in their decisions to vaccinate across the lifespan. Thank you for your considerations of our views on this important public health issue. Thank you so much.
Thank you for your comments. Our next speaker is Marla Dalton. Ms. Dalton.
Thank you, and good afternoon. I am Marla Dalton, Executive Director and CEO of the National Foundation for Infectious Diseases, or NFID. On behalf of NFID, as a long-standing partner of CDC, thank you to all of the members of ACIP for the valuable work you all do. As you know, influenza activity for the current flu season has been low, which is largely attributed to infection control measures implemented during the COVID-19 pandemic, as well as the limited number of children interacting in person in schools across the U.S. But even though flu activity has been low, we remain aware that it could increase at any time. And as we look ahead to the 2021-2022 respiratory season, we recognize that more children will likely be back at school, learning in person. There may be less attention to social distancing, face masks, and hand hygiene, and family and friends who have stayed apart throughout the pandemic will reunite. Flu will be back, and we must prepare. Flu kills tens of thousands of people in the U.S. every year. In addition, pneumococcal disease can be deadly, especially for adults aged 65 years and older. And many of the same individuals who are most vulnerable to serious complications of COVID-19, including older adults, those with chronic health conditions, and underrepresented minorities, are also at greater risk for complications from flu and pneumococcal disease. In the U.S., communities of color bear a disproportionate burden of serious flu illness and related outcomes, along with historically lower flu vaccination rates. A recent NFID survey of U.S. Black adults found that only 54% had received or planned to get a flu vaccine during the current flu season. And the top reasons cited were concerns about potential side effects and the misconception that you can get flu from the vaccine. We all must make it clear that there are safe vaccines available to help prevent flu, and you simply cannot get flu from the vaccine. Additional information about the survey, as well as webinars and other resources to help healthcare professionals address these misconceptions, is available on the NFID website at www.nfid.org. As we all continue to fight the ongoing COVID pandemic, we need to prioritize prevention and treatment of all infectious diseases, including flu and pneumococcal disease. Annual flu vaccination, as recommended by CDC, can reduce hospitalizations and can help save lives. With new vaccines to prevent pneumococcal disease on the horizon, we all must work to ensure that patients understand the burden of these diseases and the importance of prevention through vaccination. Now more than ever, the work of ACIP in guiding U.S. immunization policy is vital to protecting public health. So on behalf of NFID, thank you all for your dedicated service.
Thank you very much for your comments. Our next speaker is Mr. Cesar Ochoa. Mr. Ochoa.
Thank you. Good afternoon. My name is Cesar Ochoa, and I live and work in Ciudad Juarez, Mexico, across the border from El Paso, Texas. I am here as a member of the Mexa Contingencia COVID de Chihuahua, a private public task force put together to address the many problems created by the pandemic in our region. Thank you for allowing me to present our concerns before this scientific forum. This presentation intends to give you additional information on the issues raised by my colleague Emma Schwartz. I will be speaking about my area of the border, but my remarks should be substantially true for all the twin cities located on both sides of the U.S.-Mexico border. Allow me to emphasize that the appeal that Ms. Schwartz and I are making has enormous economic, political, and humanitarian repercussions, but it is primarily a scientific one. I have been preparing for this 3-minute presentation for 3 days because lives are at stake. Hundreds of lives can be saved if our hypothesis is correct, and if Emma and I can convince you to work together to address its consequences. Our hypothesis is that herd immunity threshold calculations for the American border towns must consider the population of the Mexican side of the border as well. We believe that your country's program to vaccinate the population that lives on the American side of the U.S. border will not fully succeed unless we work together to vaccinate the people on the Mexican side of that same border. In other words, the herd is not only the population of El Paso, it is a combined population of El Paso and Juarez. Assuming this is correct, if you vaccinate 100% of the citizens of El Paso, for example, you would have vaccinated less than 1/3 of the herd because Juarez has 1.6 million citizens. The twin border cities are quite literally joined at the hip, and our destinies, including the epidemiological ones, are inextricably linked. The border that separates the cities is permeable, very, very permeable, and it would be naive to think that the virus will honor any border wall. Now, one statement of fact. Mexico's official sources indicated on February 19 that the total number of vaccines administered as of that date, countrywide, was 167,000 doses. 167,000. We are your partners and we need help. Therefore, we respectfully come before you with an invitation and a promise. Our invitation is to work together to determine if our hypothesis regarding the border herd immunity threshold is correct. Our promise is that if our hypothesis is correct, you will find in our group a tireless ally who will overcome every single one of the many obstacles in our path to achieve the required herd immunity in our region, US and Mexico. We have a commitment with our region, and we will work with the Mexican federal government, with you, and with anyone else who is willing to help. Thank you for your consideration.
Thank you for your comments. Our last speaker is Dr. Eve Schwitzer. Dr. Schwitzer, are you there? Apparently not. Okay, so very good. Then that ends our public comment session. We're going to move on to the vote on the rabies vaccine. So we have already had a motion and a second on the first proposed language. We're going to turn our attention first to the second proposed recommendation. And so I will try to read this in my best audible.com voice. And here we go. So the recommendation is as follows. ACIP recommends an intramuscular booster dose of rabies vaccine as an alternative to a titer check for immunocompetent persons greater than or equal to 18 years of age who have sustained an elevated risk for only recognized rabies exposures, i.e., those in risk category number 3 of rabies PrEP recommendations table. The booster dose should be administered no sooner than day 21, but no later than 3 years after the second dose PrEP series. So, are there any comments at this point? Dr. Paling. Dr. Paling, your hand was up.
Yes, I'm sorry. Thank you. I do agree that this is improved. I have one question. Should only in 4 be reversed? So it's only 4 recognized. Thank you.
So the reason the word only was there was to make sure that it was clear that all of the risk groups actually have risk for recognized exposures. It's category, risk category number 3 is the one that has risk for only recognized. They do not have risk for unrecognized exposures.
Dr. Paling, does that answer your question?
Yes, thank you.
Thank you. Dr. Long, you have a question or comment?
I have a comment. It's just like Dr. Paling's, but I think maybe you just misunderstood her. We're just talking about the language here. Because of where you put the only, it makes it sound like we're not interested in people who have unrecognized risk. A very small 2-word change would make it clear. Who have sustained an elevated risk for rabies only from recognized exposures. And Dr. Paling and I then would be happy, and you could do that later. I don't think it substantially changes it, but it makes it clear. The only's in quite a little bit the wrong place.
Thank you for those comments. So what we'll do is, rather than what we've done in the past, and we'll do for this, is that we'll do the wordsmithing, the fine tuning of the language offline, and we'll carry those comments in, but leave the intent of the recommendation intact. Is that satisfactory, Dr. Long?
Absolutely.
Thank you very much. Dr. Daly.
One quick point of clarification. So for those less than 18 or immunosuppressed, existing recommendations stand, correct? So no change for those.
At this time, yes, they are unchanged. We will wait until we hear from the AAP and the COID regarding children, individuals less than 18 years of age.
And Dr. Daly, we can clarify that in our guidance and in the policy note that frames the recommendation.
Perfect, thank you.
Very good. Are there any other comments, questions? All right, so would someone like to motion that we accept this? Please raise your hand. Dr. Long, I see that you make a motion. Is that correct? Go forward.
A motion to accept.
Thank you very much. Dr. Alt, I see that you're the second one up. Do you want to make a motion to second?
I do. I will second it.
Thank you. Thank you, sir. Is there any other comment, question? I'm just looking at the list. I'm not seeing any. Okay, so we will proceed to vote. I'm going to ask you all, as we have done in the past, to please activate your cameras. And let's see if we can get pictures of everybody up there. I just activated one. Do we have all the voting members activated?
Yes, it looks like we do.
Okay.
We are pushing buttons on our
You are
activate
absolutely. You are
camera, but
all
it's not-
activated. I'm told that I can see all your bright and smiling faces. Okay. Good. So I will now proceed to read the first proposed recommendation, and then we'll take a vote. Now, Dr. Cohn, this will be a verbal vote. Is that correct?
Yes, so we'll go through and do a verbal yes, no for proposed recommendation number 1, and then for the second motion on the table. And then after that, if anyone wishes to explain their vote, if regardless of the vote, they are welcome to do that after both votes are taken.
Okay. So proposed recommendation number 1. ACIP recommends a 2-dose, 7 days, intramuscular rabies vaccine series in immunocompetent persons greater than or equal to 18 years of age for whom rabies vaccine pre-exposure PrEP is indicated. So I'm going to call the roll with the chair voting last, and let's begin.
And this is, Amanda, just one quick reminder to please indicate for the first vote if you have any conflicts of interest related to this vote.
And we're only voting on the first proposed recommendation. Dr. Alt, would you please?
Alt, no conflicts, yes.
Ms. Bata.
Bata, no conflicts, yes.
Dr. Bell.
Bell, no conflicts, yes.
Bernstein.
Bernstein, no conflicts, yes.
Dr. Chen.
Chen, no conflicts, yes vote.
Dr. Daly.
Daly, no conflicts, yes vote.
Dr. Fry.
Fry, no conflicts, yes.
Dr. Cotton.
Cotton, no conflicts, yes.
Dr. Lee.
Lee, no conflicts, yes.
Dr. Long.
Long, no conflict, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Paling.
Paling, no conflicts, yes.
Dr. Sanchez.
Sanchez, no conflicts, yes.
Dr. Talbot.
Talbot, no conflicts, no.
I'm sorry, can you repeat that? You trailed off at the end. I want to make sure I captured it correctly.
Kip Talbot, no conflicts, and I vote no.
Thank you. Romero, no conflicts, yes. So, Dr. Cohen, we have 14 yeas and 1 nay. The proposed recommendation carries. Thank you very much. So let's turn our attention then to the second proposed recommendation. All right, so again, I will read the recommendation and then take the roll as we did before. ACIP recommends an intramuscular booster dose of rabies vaccine as an alternative to a titer check for immunocompetent persons greater than or equal to 18 years of age who have sustained an elevated risk for only recognized rabies exposures, i.e., those in risk category 3 of rabies PrEP recommendations table. The booster dose should be administered no sooner than day 21, but no later than 3 years after the after 2-dose PrEP series. All right. So we'll begin again voting. Well, let me ask this. I'm sorry, forgive me. I'm getting ahead of myself. Are there any other comments for this before we open the vote? Okay, I'm none seeing. Then I'll begin. Again, we will start with, well, let's do it a little differently this time. Let's start with Dr. Talbot.
I vote yes.
Okay. Dr. Sanchez.
Sanchez, no conflicts, yes.
Dr. Paling.
Paling, yes.
Any conflicts? Oh, you don't have to do it. Okay, thank you, Dr. Cohen. Okay, then we move on to Ms. McNally.
McNally, yes.
Dr. Long.
Long, yes.
Dr. Lee.
Lee, yes.
Dr. Cotton.
Cotton, yes.
Dr. Fry.
Fry, yes.
Dr. Daly.
Daly, yes.
Dr. Chen.
Chen, yes.
Dr. Bernstein.
Bernstein, yes.
Dr. Bell.
Bell, yes.
Ms. Bata.
Bata, yes.
Dr. Alt.
Alt, yes.
And Romero, yes. So, Dr. Cohen, this recommendation passes unanimously, and we completed the votes.
Great. We'll now go through and see if any members would like to comment on their vote, regardless of if they voted yes or no. And rather than going through everyone, we'll just have you raise your hand if you would like to comment, and we'll give a minute to let people decide.
Right. Dr. Lee, please go ahead.
Thanks much. I just wanted to reemphasize the importance of clear clinical guidance, particularly around proposed recommendation number 2. I still worry about the gaps that might occur with implementation and want to ensure that we're optimally protecting all of those who might fall in the booster category, particularly group 3, with the knowledge that travelers in particular are pretty proactive about getting vaccinated or ensuring they're protected. So it's the non-traveler groups and thinking about implementation there that would be incredibly important.
Thank you. Dr. Chen.
Yeah, I'm a travel medicine physician on my day job, and I feel on a daily basis the intricacies of trying to implement rabies vaccination. And sometimes with short notice of travel, we're unable to deliver the full rabies series with the 3 doses. So I do appreciate kind of the intent where we are data-driven in making the decision for having a 2-dose series. And I did appreciate the discussion that we had today to kind of really parse some of the questions that we had, the data that we may have missing that we would like to explore a little bit further to be able to further develop these recommendations. So I did appreciate kind of the decision-making and the discussion that we had here today.
Thank you very much. Dr. Fry.
Thank you. I just wanted to thank the committee for all their input, regardless of how anyone voted, because I understand this is a very serious disease that has almost 100% mortality. In fact, most of us think it is 100%, except perhaps an exception of 1 or 2 people that we know of. But we understand your concerns, and we spent a lot of time going back and forth with these discussions. They were quite rigorous, and I just want to thank you for all the input that you had in allowing us to be able to make changes that probably improve what we presented here, improve the vote. Thank you.
Thank you. Dr. Bell.
Thank you. I just wanted to reiterate Dr. Lee's comments and say that this is a not unfamiliar situation from an implementation perspective in which the subject matter experts about the vaccines are actually not the subject matter experts about the implementation. And so to do this effectively requires the people whose bugs these are, like rabies, for example, to reach across and learn how to do that to the travel medicine community, to the pediatrics community, to the veterinarian community, and to the people who understand clear communication to make the website really crisp in order for this really to work and in order for it to be effectively communicated. So I just want to reiterate how important that is, and that it's a type of activity which may be somewhat unfamiliar to the rabies experts who obviously have a lot of important things to contribute, but this is a little bit of a different tack.
Thank you. Dr. Long.
I would like to say that I find this very reassuring, the process very reassuring. I think it is as important that we diminish vaccine doses, if that is appropriate, as if we recommend further vaccines or further doses. So that to maintain the trust of our populace in our careful deliberation about what one needs, the confidence that the rabies people have that this will be effective, it is terrific to be able to decrease a dosage that then cannot give further benefit than anything that it could do. Any risk would be unacceptable. So I am very happy that we can do this once in a while.
Thank you. Are there any other comments? So in closing then, I don't see any. Let me just say that I'm thankful and I want to thank Dr. Fry, Dr. Blanton, Dr. Rao for an outstanding job. I sat on this work group committee and actually entered the committee with some trepidation as to whether this was an appropriate step. And I think they've assembled amassed really a large set of data which supports these recommendations, and I think it's the appropriate thing to do. So again, thank you very much for this time, and to you, Dr. Rao, who had a marathon session this morning. So thank you, and we'll move on now to the next topic. So our next topic is dengue vaccine, and I'm going to ask the work group chair, Dr. Paling, to please go forward. Oh, excuse me. Let me clarify something. I'm sorry. I'm remiss. There were two topics that were not covered here: the approach to rabies post-exposure prophylaxis and work group interpretations of data around rabies immune globulin and the next steps for the work group. So, as we have said, and for the new members, we want to foster discussion. We never want to stifle it. And because the discussions were so robust and important, we decided to keep going. And these two topics will be either addressed at another session tomorrow or in a half-day session to come forward. So I'm looking over to my side to Dr. Cohen, and she's nodding. That's the beauty of having somebody, the executive director in the room. All right, so having said that, then let me turn the attention to dengue vaccine with an introduction by Dr. Paling. You may please turn your cameras off, and we'll go forward. Please, Dr. Paling.
All right. Good afternoon, and welcome to this conversation of the ACIP Dengue Vaccine Work Group. Next slide, please. And a special thanks to all the members of the ACIP Dengue Vaccine Work Group. We have had very robust conversations. We have ACIP members, our lead, CDC lead, Dr. Gabriela Paz-Bailey, who took over after from Dr. Steve Waterman, and then our ex officio, our liaison representatives, consultants, and CDC contributors. Next slide, please. The Dengue Vaccine Work Group has actually had quite a history, and as a reminder, in 2017, the Dengue Epi and Vaccine Development Work Group was formed. In 2018, the work group was put on hold, the flavivirus work group split, and the Dengue Vaccine Work Group is formed now. In 2019, there was lots of discussion, the phase 3 results, the safety and pharmacovigilance, grade, cost effectiveness, dengue diagnostics, partial effective vaccines, dengue vaccines in the Philippines, the VRBAC, and FDA approval. 2019 was focused on the vaccine acceptability, the WHO global position, feasibility, health equity. And now in 2021, we are working on dengue IgG test evaluation, which we will present, and we still have to work on the evidence to recommendation framework and hope to have a draft recommendation to ACIP later this year. Next slide. Since November, the Dengue Vaccine Work Group has discussed Zika virus infection enhances future risk of severe dengue disease, an update on developmental status of a new dengue IgG rapid test to determine past infection, feasibility of the CYD Tbe vaccination program, CYD Tbe and health equity, evaluation of commercial dengue IgG test, and a straw poll and discussion has begun on evidence to recommendation. Next slide, please. CYD TCV vaccine presents novel challenges due to being the only vaccine requiring pre-vaccination screening. A test for pre-vaccination dengue screening needs to be both specific to minimize the vaccination of seronegative children, as well as sensitive to maximize the identification of children who can benefit from the vaccine. The work group is reviewing data and considering including recommended test performance characteristics in the MMWR accompanying a future ACIP recommendation. Next slide, please. Anticipated for the 2021 calendar year is further work group discussions to finalize the evidence to recommendations framework, in a spring ACIP meeting presenting the ETR and draft work group recommendations, and those are successfully achieved a vote in June 2021. Next slide, please. All right, next we will have Dr. Freddie Medina presenting the evaluation of commercial dengue virus IgG tests for pre-vaccination screening. And next slide. And as you listen to this presentation and then the follow-up discussion with Dr. Paz-Bailey, we're asking you to think about any other considerations the work group should address. At that, I'll turn it over. Thank you.
Thank you. Sorry, I was having a little trouble turning on my mic. Thank you very much. So our next speaker is Dr. Medina, and I'll ask them to come to the podium for results of dengue test interpretation evaluation. Dr. Medina.
Dr. Medina, if you're there, we can't hear you.
Can you hear me now?
Yes, we can.
Okay. So today I'll be talking about our evaluation of commercial dengue virus IgG tests for pre-vaccination screening. So this work was done here at the dengue branch, and Jorge Munoz is the laboratory director. I'm the immunodiagnostic lead here at the dengue branch. Dengue fever is caused by 4 closely related but distinct virus types, and in theory, if a person can be infected with dengue virus 4 times in their lifetime. I'd like to start my talk by showing one of the main findings of the phase 3 dengue vaccine studies that show that in individuals without previous dengue exposure or seronegative, the vaccine can mimic a primary dengue virus infection and increase their risk for hospitalization and severe dengue. In individuals with prior exposure to dengue virus and seropositive, the vaccine shows a protective effect that reduces hospitalizations and severe dengue. In May 2019, the FDA approved Sanofi Pasteur's vaccine named Dengvaxia to prevent dengue disease caused by all 4 dengue virus serotypes in children aged 9 through 16 years, living in areas where dengue virus is endemic, for example, Puerto Rico, American Samoa, Guam, and the U.S. Virgin Islands, who have laboratory-confirmed previous dengue infection. Before vaccination, healthcare providers must evaluate children for prior dengue virus infection using medical records of a previous laboratory-confirmed infection or through serological testing prior to vaccination. Uninfected or seronegative children should not be vaccinated. To develop a target product profile, or TPP, for a dengue IgG pre-vaccination screening test, meetings with experts and country representatives from Latin America and Asia Pacific regions were organized by the Partnership for Dengue Control. In the link at the bottom of the slide, you can find the preliminary draft of the TPP resulting from this meeting. The table shown here presents an example of the positive and negative predictive value using a population with a dengue virus seroprevalence of 50%, similar to what is observed in Puerto Rico. A test with 70% sensitivity and 98% specificity would have a 97% positive predictive value and a 77% negative predictive value, resulting in a benefit for 350 true positive individuals for every 1,000. The risk of potential harm by inadvertently vaccinating seropositive individuals would occur in 10 out of every 1,000 individuals. The true negative individuals that should not be vaccinated is 490 out of 1,000. Those that should be vaccinated but are not identified due to a false negative result are 150. As you can see in this table, if the sensitivity of the test is raised from 70% to 90%, the negative predictive value raises above 90% and increases those that would benefit from vaccination. This shows a need for high test performance in areas with moderate dengue virus endemicity. There are problems with the currently available dengue virus IgG test. First is that the current commercial kits were developed for the detection of high IgG antibody levels, such as those typically found in recent or acute secondary infections. There are only few studies that have evaluated IgG test performance using specimens from remote, those that primary or secondary infection. When I say remote infections, I'm referring to infections that occurred at least a year prior to sample collection. Lastly, many dengue virus IgG tests were developed prior to the Zika virus outbreak, so most of them have not been evaluated for cross-reactivity with Zika virus in endemic areas. Our challenge is to find dengue virus IgG tests with high sensitivity for low levels of dengue IgG and with high specificity and no cross-reactivity with Zika virus antibodies. Previous evaluations of dengue virus IgG tests have potentially been biased by the selection of specimens. The strategy these studies used consisted of using PRNT-confirmed flavivirus samples from West Nile, Japanese encephalitis, and Zika virus, then performing a test to detect IgG antibodies against the dengue virus non-structural protein NS1, and if the sample was positive, it was considered as having been exposed to dengue virus. This may have resulted in the exclusion of flavivirus specimens that are cross-reactive with dengue virus and could have resulted in artificially low levels of cross-reactivity among the evaluated dengue virus IgG screening tests. So the objective of our study was to perform an independent evaluation of sensitivity and specificity of selected dengue virus IgG tests for their potential use in pre-vaccination screening with the following emphasis: detection of monotypic dengue virus infections long after exposure and cross-reactivity of anti-Zika virus antibodies in dengue virus IgG tests. So this study was limited in scope and size and was not intended as a large-scale evaluation. So our methods were that we reviewed, manufactured, and peer-reviewed independent evaluations of more than 30 anti-dengue virus IgG tests made for the detection of recent dengue virus infections. We evaluated 7 tests with the best performance data using samples from recent dengue virus or Zika virus infection, and these samples were from 7 to 30 days after symptom onset. Then we further evaluated 5 tests with low Zika virus cross-reactivity in moderate to high sensitivity for the detection of remote dengue virus infections, so those that occur over a year after. Added to the evaluation, 1 newly available rapid test in 2 versions, rapid test 3A and 3B, made for the specific detection of anti-dengue virus IgG in remote infections. And the CDC dengue virus IgG ELISA was included in the evaluation as an additional test. We evaluated the best performing tests with challenging samples from early convalescence and with high Zika virus IgG and neutralizing antibodies. And we compared evaluations from the CDC and the manufacturer of the new rapid test. All tests were purchased by CDC without established agreements with manufacturers, and sample selection was made independently and confidentially by CDC. So the composition of our sample panel for remote infections, we had unexposed, and those are PRNT negative specimens from Puerto Rico and Alaska. We had remote infections, so those that were collected over a year after infection. And we have dengue primary, which were those that have neutralizing titers with a cutoff of 50 for a single serotype. Dengue virus secondary, and those are with neutralization titers to 2 or more serotypes, and Zika virus primary specimens. And these had a PRNT50 neutralization to Zika virus greater than 80 and no neutralization to dengue virus serotypes. And we also had another group, which are Zika virus RT-PCR positive. They were dengue virus and Zika virus IgG negative in an acute specimen. And we had the specimen that was evaluated was collected 3 to 4 years after infection. And we've had very limited dengue virus in between. So the tests with the best performance were evaluated with additional specimens. And in this group, we added unexposed. So we have additional specimens that were PRNT15 negative and they were from Puerto Rico from our cohort and from Alaska. And we also had remote Zika virus primary specimens that were obtained from a cohort in Nicaragua. And these are specimens that were RT-PCR positive in an acute specimen and dengue virus and Zika virus inhibition ELISA negative. And then the specimen was collected, that was tested, was collected approximately 1.5 to 2.5 years after the infection. Because Zika virus is the main cause of cross-reactivity in areas of co-endemicity with dengue virus, we developed an additional panel to further challenge the best-performing test, which included cases of Zika virus infections confirmed by RT-PCR with no previous dengue infections. These samples were selected for high IgG ELISA and PRNT titers and were obtained 3 to 4 months after infection. We included these samples to assess test performance in a scenario of Zika virus transmission that could potentially affect pre-vaccination screening. These results are presented for the 3 best performing tests and are not included in the specificity estimate we will show now. So now I will show the performance evaluation results. This is a visual summary of our results from the initial evaluations that includes 7 commercial tests and the CDC IgG ELISA. In our specificity panel, which is composed of unexposed or Zika virus primary specimens, no false positives were observed in the unexposed population, but false positives seen in red circles are detected in the primary Zika virus population. The highest cross-reactivity was observed in the CDC IgG ELISA, where 13 out of 14 specimens tested positive, while most of the tests in our evaluation had low cross-reactivity. Note on the top that the CDC IgG ELISA, which uses virus-like particles as antigen, detects the maximum number of positives, but it is highly cross-reactive and meant to be used in combination with PRNT confirmatory testing. In the sensitivity panel, the ELISA test 2 and 2 versions of rapid test 3, A and B, performed well. ELISA test 1 had high sensitivity but exhibited higher cross-reactivity with Zika virus than what is desired. ELISA test 3 and rapid test 1 had very low sensitivity, where more than half of the dengue virus specimens were missed, and no dengue virus primary specimens were positive. Rapid test 2 did not detect any dengue virus specimens, despite performing well in our initial evaluation with acute dengue virus specimens. Based on these initial findings, we decided to add additional negative and Zika virus primary specimens to further evaluate ELISA test 2 and the 2 versions of test 3. This table shows the performance of dengue virus IgG tests in percentages with the initial 44 specimens used in our panel, plus the additional negative and Zika virus primary specimens added to further evaluate ELISA test 2 and rapid test 3A and 3B highlighted in the red boxes. The sensitivity for the dengue virus IgG ELISA is high, but the specificity is low. ELISA test 1 had moderate sensitivity and specificity. ELISA test 3 and rapid test 1 and 2 performed poorly. ELISA test 2 and both versions of rapid test 3 displayed moderate sensitivity ranging from 68 to 82% and very high specificity above 97%, despite the inclusion of Zika virus specimens with other negative specimens. This table shows the cross-reactivity of Zika virus specimens in the dengue virus IgG test evaluated. The level of Zika virus cross-reactivity in the CDC dengue virus IgG ELISA is high, and it's 93%. A moderate cross-reactivity was observed in ELISA test 1 and low cross-reactivity in ELISA test 3 and rapid test 1 and 2. The level of Zika virus cross-reactivity was low and equal to or less than 8% in ELISA test 2 and both versions of rapid test 3 highlighted in the red boxes. ELISA test 2 and rapid test 3 were also evaluated with a selection of challenging Zika virus primary samples with the highest Zika virus IgG OD values and neutralizing antibody titers. These samples were collected approximately 3 to 4 months after Zika virus infection and represent a worst case scenario in the event of the emergence of Zika. ELISA test 2 had the highest level of cross-reactivity with these challenging specimens and nearly 4 times higher than what was observed in the evaluation using remote specimens. While the results from both versions of rapid test 3 were similar to that seen using remote specimens. Now I'll show the results of a comparison of CDC and manufacturer evaluations for rapid test 3A and 3B. This table shows a side-by-side comparison of evaluations performed by CDC and the manufacturer of rapid test 3. The results from the manufacturer's evaluation were presented to the Dengue Vaccine Work Group in May of 2020. The manufacturer's and CDC evaluations were performed independently, and the specimen panel sources are different. The sensitivity observed by the manufacturer is higher than that observed by CDC for both versions of the test, and could be in part explained by the higher proportion of monotypic specimens used in our evaluation. The specificity observed by the manufacturer was 98% in rapid test version 3A, and they decided to make modifications in this test to increase its specificity, which increased to 99% in version 3B. The CDC evaluation observed no differences in specificity between the two versions of rapid test 3. This table shows a side-by-side comparison of Zika virus cross-reactivity in rapid test 3 evaluations by the manufacturer and CDC. The manufacturer did not see any cross-reactivity of Zika virus specimens in the 3A version, while the 3B version has not yet been evaluated. CDC did see a low level of cross-reactivity of 6% for both versions of the test as presented in the previous slides. These Zika virus remote specimens are from cohorts in Puerto Rico and Nicaragua. There is RT-PCR confirmation in an acute specimen in 29 out of 36 cases. The other 7 Zika virus specimens were from Puerto Rico and selected based on virus neutralization testing. This is data provided to us by the manufacturer of rapid test 3, showing that the cross-reactivity with other relevant flaviviruses is low in the rapid test version 3A. The cross-reactivity of all flaviviruses was less than 3% in the test. So the limitations of our study are that the number of the specimens in the evaluation was small, particularly for sensitivity. The sensitivity of dengue virus IgG test may be underestimated due to emphasis in remote primary dengue virus infections. A high proportion of Zika virus samples included in the specificity panel are greater than the prevalence in the target population. The cross-reactivity with Zika virus has been addressed in the context of past infection, but may need additional testing of early convalescent specimens. In conclusion, there are commercial tests currently available that could be potentially used for pre-vaccination screening. 3 anti-dengue virus IgG tests perform with high specificity, 97 to 98%, and moderate sensitivity, 68 to 82%, with low Zika virus cross-reactivity, 6 to 8%. Half of the commercial tests evaluated performed poorly, sensitivity less than 30% for the detection of anti-dengue virus IgG antibodies long after exposure, despite their demonstrated use to diagnose recent infections. Test sensitivity was higher for multi-typic dengue virus infections than monotypic dengue virus infections. I'd like to finally acknowledge all the people involved in this study. Thank you.
Thank you for that presentation, Dr. Medina. So we're going to hold questions until we hear Dr. Paz-Bailey's presentation, which will be next. So Dr. Paz-Bailey, would you please go forward?
Yes, thank you. And we will need to move to the next presentation. Can someone help me do that?
We're doing that right now. Thank you.
Thank you. Great. Well, thank you so much for the opportunity to share with you the dengue vaccine workgroup perspective. And sorry, I'm just waiting for the slide to move forward. There we go. So as Dr. Medina said, the CDC evaluation of dengue IgG tests was small and generalizability is limited. But since previous evaluations could have been biased by excluding dengue IgG positives from the specificity panels, the goal of this evaluation was to address problematic areas that could be affecting the estimates of sensitivity, specificity, and cross-reactivity. And the results suggest that most of the tests that are intended for acute diagnosis did not perform adequately for detection of dengue IgG antibodies in the context of pre-vaccination screening, especially in terms of sensitivity. One ELISA assay and two versions of a rapid test perform best. The CDC evaluation results may be conservative, meaning that they may represent minimum performance since the samples were selected to highlight problematic areas. So we have a large proportion of monotypic infections in the estimates for sensitivity, and in the specificity panel, we have a large proportion of Zika samples. And I also wanted to add that the manufacturer is planning on conducting a large prospective evaluation of the rapid test, recruiting participants in Puerto Rico and the mainland, and their goal is to recruit about 650 participants, and they're planning on starting recruitment this year. So one of the dengue vaccine workgroup priorities has been assessing that acceptable tests exist or that they will be available for the safe implementation of pre-vaccination screening. And this evaluation has helped clarify that there are a few tests that could be used for this purpose. The workgroup is currently completing the evidence to recommendations framework, and the draft ETR and recommendations will be presented to ACIP in the spring and potentially present recommendations for a vote in June. The workgroup is also working on a target product profile that would include minimal and optimal performance characteristics of the tests used for pre-vaccination screening. And the target profile would be included in the clinical guidelines in the MMWR that presents the ACIP recommendations. The jurisdiction will have to play a role to ensure that these test characteristics are met for the tests used for pre-vaccination screening. This is an example target product profile that was developed by the Partnership for Dengue Control and the Global Dengue and Aedes Transmitted Disease Consortium. And this was done after extensive consultations with vaccinologists, country representatives, key opinion leaders, and diagnostic manufacturers. And the table shows the minimal and optimal sensitivity and specificity, and we also added the CDC evaluation findings in the last column. So this TPP proposes a minimal sensitivity of 85% and optimal of 95%. And you can see that the tests with best performance had lower sensitivity than that recommended by the TPP. The TPP values for specificity are 95% for the minimal and 98% for performance. And the values in the CDC evaluation were higher than the minimal recommended for the 3 tests and met the optimal specificity for the 2 rapid tests. But again, just remember that the CDC evaluation may have resulted in conservative estimates for sensitivity. So the international target product profile can be adapted for the U.S. Territories, and specificity is considered to be more important than sensitivity to cause no harm. And a subgroup from the dengue vaccine workgroup is working on developing the TPP and presenting this later for workgroup review and consideration. And this table shows the results of mathematical modeling to estimate hospitalizations averted and additional hospitalizations by erroneously vaccinating seronegatives after screening with a test with imperfect sensitivity. And it's work that was done as part of the cost effectiveness analysis. The model simulates a 10-year cohort of 9-year-olds in Puerto Rico and uses a pre-vaccination screening test with 80% sensitivity and 98% specificity. And the coverage of screening is set at 80% of the population, with all those testing positive being vaccinated. And the table in the rows show the results for different seroprevalence scenarios among children ages 9. That is the age when vaccination would start. So at 30% seroprevalence, 1,655 hospitalizations would be averted after 10 years of vaccinating, and 123 additional hospitalizations could be caused for a ratio of 13 averted per 1 caused. And at a seroprevalence of 15%, the ratio is 60 to 1, and 135 to 1 at a seroprevalence of 60%. So we would like to pose the following questions to ACIP. Does ACIP concur with including pre-vaccination screening dengue IgG test target product profile in the MMWR that accompanies the ACIP recommendations? And then going back to Dr. Palin's question, are there other considerations that the work group should address? So this is the end of my presentation, and we would like to answer any questions or hear your comments.
Thank you very much, Dr. Boss-Bailey. These two presentations are open for discussion. Are you gathering your thoughts, I think? Dr. Lee, you have a question, comment?
Thank you. I wanted to ask if you could please remind us, independent of serologic status, if there are age-associated differences in hospitalization.
Sorry, Dr. Lee, can you repeat your question? Is it that if the rates of hospitalizations are different by age?
Yes, I'm wondering if you can take away the confounding due to serologic status. Is a young child more likely to be hospitalized at baseline, sort of given the same serologic status? How do I say this? So in the net, yeah. Okay, sorry, go ahead.
Yes, I think I understand your question. So first, in terms of surveillance at the population level, we know that the age group that has the highest rates of hospitalization is the ages 10 to 19. So both incidence of cases and hospitalizations are the highest among that age group. And in terms of risk factors for severe dengue and for hospitalization, secondary dengue infection is the most important risk factor. So rates of hospitalization and severe dengue are higher and among people who are seropositive. So those who have had dengue infection at least once before.
So there's no specific, like taking away secondary, or amongst all secondary dengue cases, there's such confounding by age in terms of the timing of that secondary infection that it's difficult to distinguish whether or not the rates of hospitalization actually differ fundamentally by age. Is that correct?
Yeah, so again, the rates of hospitalization are the highest among ages 10 to 19. So is that what you're asking?
Yeah, I guess my question is that my assumption is that the 10 to 19 age group is at the highest risk for secondary infection.
Yes.
And that is why that they're more likely to be hospitalized. But if for whatever reason, like that age group were to shift in some way, I just wanted to confirm that underlying that there was no difference in hospitalization.
Dr. Boss-Bailey, I think what Dr. Lee is asking is if you were to stratify according to serologic status, what would be the hospitalization, the rates of hospitalization by age group once you've stratified by baseline serologic status? That's what she's asking, I think.
Thanks, Beth. I appreciate the translation. Having a hard time today.
you're totally right, Dr. Lee, that the highest hospitalization rate is because of the epidemiology of dengue and because we see a larger proportion of secondary infections among that age group. So just looking at seronegatives and seropositives separately, I don't know. I couldn't answer that question. I know that we have people from Sanofi in the Zoom call, and they may be able to answer it with the data from the phase 3 trial. Do we have Stephen Savarino on the call?
Yes, would someone from Sanofi care to answer that? Dr. Savarino, are you there? Are you willing to offer comment?
Yeah, this is Dr. Savarino. Thank you very much. I'm not sure I could answer that. I can come back to you on that question. Looking stratified by serostatus, the hospitalization rates. Keep in mind that in the phase 3 trials, we were focused on children from 2 to 17 years of age. So we do not have adults in that population. But
thank you.
I'll come back.
Thank you. Go ahead, Dr. Daly.
Yes, so to this first question about whether ACIP concurs with including the test target product profile, I would strongly concur. You know, I think that well-intentioned practitioners in dengue endemic areas are going to, you know, want to test and then vaccinate according to test results, but they're gonna not necessarily be able to appreciate either how baseline prevalence affects test performance or this issue around cross-reactivity. So I feel like in order to safely provide dengue vaccine, that is critically important that is included in the MMWR that accompanies any recommendations. Thank you.
Dr. Bernstein.
Thank you. I agree with Dr. Daly that it is important for the profile to be included in the MMWR. And along those lines, I was wondering, I recognize that high specificity is more important than the moderate sensitivity, but can someone articulate again why the manufacturer's sensitivity was notably higher than the CDC's?
So the specimens that were used in the panels are different. So our panel had a higher proportion of primary dengue virus infections, whereas it was the opposite in the other evaluation. So it sort of flipped, you know. So ours was, we were more concerned about, you know, looking at the sensitivity, especially because the ones that will, you know, likely benefit the most are the primary. So ours was more inclined to look at the primary infections.
And sensitivity is lower.
Sensitivity would be lower in that group.
Thank you. Dr. Maldonado.
Yeah, thank you. I just wanted to kind of bring you back to the question that Dr. Lee mentioned. So in the 2018 New England Journal paper, which was the Sanofi post hoc analysis of 3 trials, what they found, and I'm just looking at the data here, was that among dengue seronegative participants, this is a vaccine and control trial, dengue seronegative participants aged 2 to 16, the cumulative 5-year incidence of hospitalization for lab-confirmed dengue was 3.06% among vaccine recipients and 1.87% among controls, with a hazard ratio of 1.75 for the vaccinees. However, the study also showed that the vaccine was protective for seropositive children. So among dengue seropositive participants 2 to 16 years of age, the cumulative incidence of hospitalization was 0.75% compared to 2.47 among controls who didn't receive the vaccine. And among children 9 to 16, the cumulative incidence of hospitalization is similar. It was distinct with 0.38% for seropositives versus vaccines versus 1.88% among controls. And also, finally, the same phenomena was seen in older children, too, with seronegative kids aged 9 to 16 having a hazard ratio of 1.41. So clearly, the vaccine was seroprotective across a wide span of previously seropositive kids from as young as 2 to 16 years of age.
Dr. Long.
In reference to Dr. Maldonado and Lee's question, I think we would like to have the dengue experts clarify what I think is the message. The message is that the risk of severe hemorrhagic dengue is related to your second episode of dengue. And it is not important when that is in your life. It is the second episode. So the vaccine would likely want to be a velvet harpoon to replace a second infection, being, first of all, dangerous if it was your first experience and not needed if it was your third experience. So it seems like a very tricky vaccine, but am I correct in my understanding of the risks of severe dengue are related not so much to your age, but to how many times you have or haven't seen dengue in the past, and
Yes.
what serotypes those were?
Yes, thank you so much for that, Dr. Long. And that is correct. Your risk of severe dengue is sort of tied to that secondary infection. But I do want to clarify that there are hospitalizations and severe dengue occurring among first infections and also occurring among third and fourth infections. But the majority or a higher frequency of hospitalizations result after secondary infection. And your risk of severe dengue and hospitalization has more to do with that than with your age. And that's why, for example, in Asia, there is a shift in severe dengue and hospitalizations towards older groups because the epidemiology of dengue is changing and somehow incidence has decreased in recent years, and now older populations are more likely to be infected. So it's sort of a different epidemiology from what we're seeing in Puerto Rico and in Latin America.
Dr. Lee?
Thanks, and thanks to everybody for clarifying the original question I had. The reason I was asking that question, and perhaps this relates to what other considerations the work group might address, and I'm not exactly sure if there was an age-specific recommendation for diagnostic testing or screening for prior evidence of infection. I was thinking in my head along the lines of the trial that it might be in younger kids we would more routinely test, in older kids we might not. But I guess this clarification is then bringing to mind that I'm seeking guidance from the dengue work group about whether you would make age-specific recommendations for pre-vaccination screening, or if the intent was just anybody who receives the vaccine gets the screen.
Mm-hmm. Yes, thank you, Dr. Lee. And I wanted to add that this vaccine is only approved for use among 9 to 16-year-olds. So it's already a pretty narrow age group. And in terms of frequency of screening, what the work group has started to discuss is potentially considering rescreening every 2 years. And that is from data from modeling work, sort of suggesting that the cost effectiveness of the vaccine would be greater if you repeat screening and potentially if you do the screening every 2 years.
So I'm sorry, this is Jose Romero. So that last statement that took me a little by surprise. So you're recommending rescreening at 2-year intervals, is that correct? Or you're thinking about it?
We are thinking about it. So we are discussing that as part of the evidence to recommendations framework. And again, the children that would be vaccinated would be seropositive ages 9 to 16 years of age. So if we start next year, let's say, and we screen that age group, we will have a group of children that are seronegative. And the idea would be to have to screen those seronegative children again in 2 years to be able to detect those that have acquired dengue in the interval. But that again is still under discussion in the work group, and a decision on how that would be sort of worded in the recommendation, we haven't gotten there yet.
Thank you. Anyone else with comments? Okay, I think that's it. Thank you very much for those presentations. I'm sure we're going to have more questions in the future, and we look forward to future presentations. So we'll move on to the next group with Dr. Paling as being the work group chair. That is the Tick-borne Encephalitis vaccine. And Dr. Paling, would you please begin the introduction?
Absolutely. All right. All right. On behalf of the entire Tick-borne Encephalitis vaccine group, I want to say thank you for the opportunity to present. Next slide, please. And we have had robust discussions among the entire work group, and want to thank all ACIP members, our CDC lead, Dr. Susan Hill, our ex officio, ACIP liaisons, technical advisors, CDC participants, and the ACIP Secretariat. Next slide, please. So Pfizer has submitted a biologic license application to the FDA for their Tbe vaccine. This licensure is possible by the third quarter of 2021. And it is important to note that there has been no Tbe vaccine previously licensed in the United States, and no existing ACIP tick-borne encephalitis vaccine recommendation. Next slide, please. The terms of reference that the Tbe vaccine work group is using is to review information on Tbe, including its epidemiology, clinical presentation, diagnosis, treatment, and outcome, to review data on infection risk and burden for the U.S. civilian and military travelers and laboratory workers, to review data on vaccine safety, immunogenicity, and effectiveness, to provide evidence-based recommendation options for ACIP, to identify areas in need of further research for informing potential future vaccine recommendations, and then to publish future ACIP recommendations in MMWR. Next slide, please. Today's topics, we're going to discuss Tbe Epidemiology and Tbe Endemic areas by Dr. Susan Hill, the Tbe among U.S. civilian travelers and laboratory workers, Dr. Aaron Staples, Tbe and the Department of Defense experience by Dr. Bruce Mcclenathan, and then we're going to wrap up the presentation with a summary and next steps for the Tbe vaccine work group by Dr. Susan Hill. So we today are talking about the epidemiology. We are looking forward to trying to present the ACIP grade and ETR in June. And if we're successful in doing that, we will be prepared to vote in October, assuming licensure has taken place. Next slide. Next slide. And so thank you very much, and Dr. Susan Hill.
Thank you very much, Dr. Paling, and good afternoon, everyone. So as Dr. Paling mentioned, the work group plans to present comprehensive vaccine safety and immunogenicity information to ACIP in future ACIP meetings. So today's presentations are going to focus specifically on Tbe epidemiological aspects, and Tbe among travelers. So beginning with Tbe epidemiology, Tbe is an arbovirus in the Flaviviridae family and Flavivirus genus. There are three main subtypes of Tbe virus: the Far Eastern, Siberian, and European subtypes. The disease is endemic to parts of Europe and Asia and is transmitted mainly by ticks, but transmission can also occasionally occur through other means, including ingestion of unpasteurized dairy products, slaughtering of animals, blood transfusion, organ transplantation, breastfeeding, or from exposure to virus in the laboratory. With TBE, asymptomatic infection is common, with estimates of up to about 80% of infections being asymptomatic. When clinical illness occurs, it can be biphasic or monophasic. A biphasic course is typical for patients infected with the European subtype of the virus, with a clinical course consisting of a first febrile illness phase, followed by remission of symptoms, and then a second phase with neurologic illness. A monophasic neurological illness is more typical with Far Eastern and Siberian subtypes. Some patients only present with a non-specific febrile illness, which usually lasts 2 to 4 days. But those who develop neurologic illness, the clinical presentations include meningitis, encephalitis, or meningoencephalomyelitis. The case fatality rate and frequency of neurologic sequelae vary depending on viral subtype. With the European subtype, the case fatality rate is about 1 to 2%, with the Siberian subtype about 6 to 8%, and with the Far Eastern subtype about 20%. The studies assessing neurologic sequelae provide very variable rates, but sequelae rates from 10% to as high as 80% of cases have been reported. And the severity, as well as the incidence of disease, are highest in older persons. Children typically have a milder illness than adults. Meningitis occurs more frequently than meningoencephalitis, and meningoencephalomyelitis is rare. Estimates of the proportion of children with neurological sequelae vary, but overall they appear to occur in fewer than 10% of children, and only a small percentage of these are severe. However, some studies do suggest that cognitive problems, like impaired concentration and memory, might be under-recognized, and death is very rare. There are limited reports of TBE in various special populations. Among the small number of reports of women infected during pregnancy, the clinical spectrum of illness has ranged from mild febrile illness to severe neurologic illness. Among infants born to these women, most are reportedly healthy, even when the mother has had a severe illness. There are some older anecdotal reports of adverse outcomes in a small number of infants, but in these cases, there was no laboratory testing done to support TBE virus infection in the infant as the cause. Therefore, currently, transplacental transmission of TBE virus has not been confirmed. One case of TBE virus transmission through breastfeeding has been described. The infant reportedly had severe illness and survived with severe sequelae. When immunocompromised persons are infected, illness is typically severe, and there appears to be a higher risk of fatal outcome in these patients. Being a tick-borne disease, the distribution and activity of the vector ticks clearly affects human disease patterns and risks. So I'm going to provide some brief information about the ticks. Infected Ixodes species ticks, mainly Ixodes ricinus or Ixodes persulcatus, transmit TBE virus to humans. The Ixodes ticks are distributed in natural foci that tend to be stable over time and can be very limited in size, with hotspots as small as 1 square kilometre recognised. Their preferred sites are near the edges of forests, in areas with deciduous trees, low-growing dense bush, and low ground cover. Tbe virus infection rates of ticks are generally low, typically less than 5%, and can be variable over time. Certain recreational activities and occupations result in an increased risk for exposure to ticks. Some of the key recreational activities that increase risk include camping, hiking, fishing, cycling, bird watching, and foraging for mushrooms, berries, or flowers. And occupations that are at increased risk include forestry workers and military personnel. Tbe virus has been found in ticks in some urban parkland areas and in backyard gardens, but the risk in urban areas is considered to be very low. Before I begin to describe the epidemiology of Tbe in endemic areas, I wanted to make a few general points. It's quite difficult to assess and compare Tbe cases and data by country, and this is related to several factors. Firstly, diagnostic tests are not routinely available in many areas, and the performance of available assays varies. Secondly, there are differences in reporting practices by country, including different case definitions and case classifications, and variability in whether reporting is voluntary or mandatory. It's clear that surveillance data are of variable quality by country and over time. Data must be considered over appropriate timeframes because disease incidence fluctuates from year to year, and assessment of data from short intervals can suggest misleading trends. And finally, vaccination impacts case numbers. And although vaccination rates are low in most countries, the availability of coverage data is limited. So I'm going to begin by discussing Tbe epidemiology in Europe. Tbe was added by the European CDC to the list of mandatory notifiable diseases in 2012. During 2014 to 2018, reported cases numbered approximately 2,000 to 3,000 annually, and reported incidence remained relatively stable from 0.4 to 0.6 cases per 100,000 population. Almost all cases had disease onset during April to November, with 59% occurring during the warmest months from June through August. Disease was predominant in males with a ratio of 1.5 to 1, and the rate of reported disease was highest in adults aged 45 to 64 years. This map shows the rate of reported locally acquired Tbe cases in Europe from 2012 to 2016. This ranges from 0 Tbe cases in countries or areas in the blue colour to at least 15 cases per 100,000 population in the magenta colour. And the highest incidence of disease is reported from the Baltic countries. In terms of understanding risk for travellers, this map illustrates a few important points. Firstly, some countries have no surveillance. These are the countries on the map in the dark grey colour, so information on risk is not readily available. Secondly, there is substantial variability in Tbe incidence reported from countries in Europe. Thirdly, the granularity of data in countries is very variable. Some countries only report national data, whereas some report data at various subnational levels. And finally, when subnational data are reported, the risk is not uniform across the country. This map shows the most recent information available on the recognised area of Tbe virus transmission in Europe based on human Tbe cases, as well as Tbe infections in ticks and animals. It's important to note, however, that this area does not correspond to the risk of infection for travellers. In many areas, although infected ticks or animals have been identified, no human cases have occurred. This graph shows reported Tbe cases in Europe by country and year for a 28-year period of time from 1991 to 2018. Again, there are a few key messages that are illustrated by this graph. Firstly, it clearly shows the fluctuations in case numbers from year to year by country. Secondly, there are different disease patterns in different countries, so peaks and troughs are not synchronous between countries. And finally, trends in case numbers have been relatively stable over time in many countries, but have increased in a small number of countries and decreased in others. While there has not been a substantial increase in human TBE case numbers overall, there clearly has been an expansion in the range of Tbe virus in Europe. During the last 30 years, the geographic area with infected ticks has increased, including 2 locations further north and west in Europe, to higher altitudes with infected ticks now found at elevations over 5,000 feet, and to new foci within countries. The specific reasons are unknown and are likely related to a complex variety of factors affecting the ticks and affecting their hosts, including climatic, ecologic, and anthropogenic factors. This expansion in the range of Tbe virus transmission is not necessarily associated with an increased risk for humans or establishment of endemicity over the longer term. For example, in recent years, when there have been newly recognised foci of transmission, this has often not been associated with any human Tbe cases or only with sporadic cases. Russia was not included on the earlier graph of reported Tbe cases in Europe, as its case numbers have been substantially higher than other countries. This graph shows the Tbe incidence in Russia from 1944 to 2018. There have been 2 disease peaks, the first in the mid-1950s and the second in the mid to late 1990s, with over 10,000 cases reported in 1996. However, during the last decade, national incidence has significantly decreased. Currently, there are about 2,000 reported cases per year, and the average incidence from 2007 to 2016 was about 1.9 cases per 100,000 population. However, this was variable from region to region. For example, there were 23 regions with low incidence, 14 regions with moderate incidence, and 6 regions with high incidence. To complete the epidemiological picture, I'm now going to briefly discuss the epidemiology of Tbe in Asia. In China, incidence is about 0.3 Tbe cases per 100,000 population. There are 3 foci, one in the northeast, one in the northwest, and one in the west. However, the epicenter is in northeastern China. In Japan, only 5 human cases have ever been reported, and all are from Hokkaido, the island in the northeast of the country. 1 case was diagnosed in 1993, and 4 cases from 2016 to 2018. And in South Korea, no human cases have been identified, but studies have detected Tbe virus in ticks and rodents in dispersed areas of the country. So in summary, the epidemiology shows some key features. Firstly, Tbe can be a severe clinical illness with potentially high mortality and sequelae rates. Virus transmission occurs in focal areas during the warmer season when ticks are active, but risk can be highly variable over place and time. Finally, given the tick-borne nature of the disease, the main risk for infection occurs when humans visit settings that put them at risk for exposure to ticks, which is when they are recreating or working in tick habitats. Thank you, Dr. Romero. I'm happy to take questions.
Thank you for that excellent presentation. This topic is now open for questions. And give me a second, I've lost my list of speakers, individuals. Ms. Bata.
Thank you. I have a question. In the patterns of diseases in Europe, are any of the
slower patterns related to vaccination in those countries?
Thank you. That's an excellent question. And just let me go on to this slide I have. So a little bit about vaccination. So only approximately 50% of the countries with risk areas have vaccination recommendations for their local population. And these recommendations, when they are made, are very variable. They go from a national recommendation. Austria is the only country with a national recommendation. Some have subnational recommendations based on risk. Some have recommendations for those spending extensive time outdoors in risk areas or for certain occupational groups. So that's firstly in terms of recommendations. Secondly, in terms of government reimbursement, when there are recommendations, it's provided by less than 30% of the countries, and sometimes it's only partial reimbursement. And there is some countries where it's covered by private insurance. But that again is an issue in terms of people actually getting vaccinated. So overall, vaccination rates are generally considered to be low, ranging from a few percent up to no more than 25% in most countries. The only major exception to that is Austria, which does have typically coverage rates reported that are higher than 80%.
Thank you, Dr. Hill.
Are there any other questions from the group? I'm not seeing any. Very good. Again, thank you very much, Dr. Hills. And we'll go on to the next presentation by Dr. Staples, which is TBE among U.S. civilian travelers and laboratory workers. Dr. Staples, please.
Thank you, Dr. Romero. Just wait for the slides to come up. Thank you. Next slide. I'm going to start my presentation with discussing TBE cases that have been detected among U.S. travelers. Next slide. In terms of how TBE cases are identified in the United States, TBE is not nationally notifiable. Currently, there is no commercially available test to diagnose TBE. However, limited testing is available at certain academic centers, state public health laboratories, and a few U.S. government facilities. Some of these labs do not have TBE virus-specific testing, but they do have IgM antibody testing for a related virus, Powassan virus, that can be positive for TBE IgM antibodies due to cross-reactivity. The CDC does have TBE virus-specific molecular and serologic testing capacities available. In terms of identification of cases, it does rely on clinicians to consider TBE in the differential diagnosis for returning travelers with clinically compatible illness and pursue TBE testing. Because of this, we expect cases to be missed, but since testing is limited mostly to CDC and a few other laboratories, we believe we have good capture of cases when testing is performed and found to be positive. Next slide. To be classified as a TBE case, a traveler must have both a clinically compatible illness, so either the febrile illness or neuroinvasive disease, and laboratory evidence of infection. Laboratory evidence of infection classifies as the case either as confirmed or probable based on the level of certainty. So confirmed cases, they have to have evidence of the virus, viral antigen, RNA in the clinical sample, or have serologic evidence showing a change in virus-specific neutralizing antibody titers determined by a plaque reduction neutralization test, or have IgM antibodies with other tests for closely related arboviruses being negative. For probable cases, they have an IgM positive sample, but other related viruses have not been evaluated for. Next slide. Prior to the year 2000, there had been only one TBE case reported among U.S. travelers, namely a 4-year-old girl who traveled with her family to Hungary, where she became unwell, getting better briefly before traveling home, and then developing meningoencephalitis. However, since 2000, there have been 11 cases of TBE identified among persons who traveled from the United States, went to an endemic area, and then returned to the United States, including 10 confirmed and 1 probable case. There's typically either 1 or no cases identified per year, with the exception of 2012, when there were 2 cases identified. Next slide. This slide shows the sex and age group for the most recent 11 TBE cases. The vast majority of cases among U.S. travelers have been in males, with cases being seen in all age groups, including 3 pediatric cases. Next slide. Most of the travelers developed their symptoms of TBE either in July or August. The 1 case each had their illness onset in May and June. All diagnosed case patients had neuroinvasive disease, with roughly 2/3 or 7 diagnosed with encephalitis and 1/3 with meningitis. Next slide. In terms of outcomes, none were reported to die, though the final status was not known for 2 cases. Of the remaining 9 patients who survived, 1/3 reported having long-term sequelae, which range from mild cognitive issues in 2 patients to more pronounced neurologic issues with severe dysarthria and mild bradykinesis in the limbs in 1 patient. Next slide. 7 cases were exposed in Europe, including 2 in the Czech Republic, 2 in Sweden, 1 in Switzerland, 1 with exposure either in Switzerland or Austria, and the last in Finland. There were 3 cases where the country of probable acquisition was Russia, namely Siberia or the eastern area of Russia. And finally, 1 case was associated with travel and exposure in China. Next slide. The approximate duration of travel was documented for all cases and ranged from 7 days or 1 week up to 2 months. The median duration of travel was 24 days or roughly 3.5 weeks. Next slide. The specific activities the travelers took part in were not available for 3 or 27% of travelers. For the remainder, the most common activity reported was hiking, then substantial outdoor exposure in rural areas, such as frequent picnicking and grassy areas. 1 each reported camping, fishing, or working on a property. Just over half reported a known tick bite, with 2/3 of those with a tick bite reporting more than 1 bite. Next slide. So to summarize, over the last 21 years, there have been 11 cases, so a relatively low number of TBE cases identified among U.S. travelers. The majority of cases were in male, occurring in both pediatric as well as adult patients or travelers. None of the cases died, but 1/3 reported sequelae, though thankfully severe outcome was relatively rare. Infection was acquired in late spring into summer in countries known to be endemic for the virus. Risk activities like hiking and camping occurred in known tick habitats, with several cases reporting tick bites prior to illness onset. Next slide. Now I would like to briefly review what we know about TBE virus infection among laboratory workers. Next slide. TBE virus should be handled at biosafety level or BSL-4 or enhanced BSL-3. The latter includes precautions beyond BSL-3, such as enhanced respiratory protection, special airflow in the laboratory, and showering in and out of an area where the virus is being worked on. Most of the data on TBE virus infection and disease in laboratory workers comes from review of literature and surveys conducted by the Subcommittee on Arbovirus Laboratory Safety, or SALS. The initial survey they did was sent out in 1976 to international and national laboratories and repeated in 1978 to get data from additional labs, non-responding labs, and on any interim exposures. Since the report by SALS, there's only been 1 additional case reported in the literature, but there have been no additional surveys conducted of laboratories since the late 70s. Finally, most laboratory personnel who are working with the virus or who might be exposed to the virus in laboratories outside of the United States are routinely vaccinated against TBE. Next slide. From the SALS report, there were 45 infections or disease cases reported. With one additional case reported in 1995, that means there's a total of 46 known TBE virus infections among laboratory workers. Of these 36, or 78%, resulted in disease, including 2 deaths. Information on the route of transmission was limited among the reports, but for all known exposures, it was due to aerosolization, either during laboratory procedures or handling infected animal waste. Among the 46 cases, at least 4 occurred among U.S. laboratory workers. 3 of the 4 resulted in disease, and the 2 known deaths due to TBE in laboratory workers occurred among U.S. lab workers. All exposures for U.S. lab workers were due to aerosolization, and none of the laboratory workers have known to have received the vaccine. So overall, there has not been a large number of laboratory-acquired infections over time, but the likelihood of disease among those with known exposure is high, and among U.S. laboratory workers, half of the infected workers died. Next slide. Thank you, and I'll turn it back to Dr. Romero.
Thank you very much for that presentation, Dr. Staples. Are there any questions for Dr. Staples? And I'll give a second here for people to raise their hand. I'm not seeing any. Thank you again for that informative presentation. Next, we're going to hear from Dr. Mcclenathan on tick-borne encephalitis among military personnel and dependents. Dr. Mcclenathan.
Good afternoon. Thanks for the opportunity to speak to you today regarding the Department of Defense's experience with tick-borne encephalitis. Next slide, please. This is my obligatory disclaimer slide. Next slide. And my obligatory disclosure slide. I have no conflicts of interest. Next slide. All right, by way of background, as we've already mentioned, tick-borne encephalitis has been recognized as a public health and force health protection threat since the 1970s for U.S. service members and beneficiaries residing in or traveling to Europe. TBE risk for military families living in some host nations is estimated to be similar to other residents of those areas. Additionally, there may be locations or activities that place certain individuals or units at increased risk of tick-borne encephalitis. Next slide. Most service members that are stationed in the European Command area of operation are transferred there on orders for at least 3 to 4 years, and we call these permanent party service members. These permanent party service member populations stationed within the U.S. European Command can be at risk for tick-borne encephalitis. In addition, DoD can send service members to areas within the European Command area of operation on temporary duty. Eastern Europe adds additional temporary force members who rotate approximately every 9 months. Germany is the country in which the greatest number of service members and beneficiaries are stationed who might be at risk for tick-borne encephalitis. TBE became a notifiable disease in Germany in 2001, and the majority of cases are reported from the southern states of Baden-Württemberg and Bavaria, both which contain U.S. military installations. Military personnel may engage in activities which place them at higher risk for contact with tick vectors, to include field training exercises, outdoor work, and recreational activities such as hiking or camping. Next slide. Because of known service members and the Department of Defense beneficiaries developing TBE and its increasing prevalence, tick-borne encephalitis risk assessments have been conducted by various military organizations. The headquarters of the U.S. European Command tasked its counter biothreat cell to conduct a risk assessment, and they deemed that TBE posed a moderate biothreat. In addition, the National Center for Medical Intelligence conducted a risk assessment with similar conclusions. The need for TBE vaccination for force health protection is supported by high-level DoD leaders to include the U.S. European Command, the U.S. Special Operations Command, and the Joint Chiefs of Staff. Next slide. DoD medical leaders advocate that an FDA-approved vaccine in combination with personal protective measures will assure the best available protection for our troops and their families. Next slide. Of note, NATO nations offer their service members either of the two EMA, European Medicines Agency, approved vaccines. However, the FDA has not approved these vaccines for use by U.S. service members currently. Therefore, these vaccines are currently offered on a voluntary basis. Service members must first obtain a referral from their military provider, consulting a local host nation provider, and then obtain vaccine from that host country TRICARE provider. It's very difficult to track overall uptake through this process. In addition, there's no mechanism for civilian contractors and civil servants working in these regions, which can be multi-year assignments, to obtain TBE vaccine through their insurance. Next slide. So with that background, I'd like to transition a little bit to the DoD's experience with tick-borne encephalitis over the last several years, specifically from 2006 to present. Most of the cases have been well described by Dr. Mancuso and colleagues in the Medical Surveillance Monthly Report dated November 2019. In this article that you see referenced here by Dr. Mancuso et al. Described 8 individuals who developed TBE between 2006 and 2018. Since this publication, we've identified a single additional case that occurred in 2020 within the Department of Defense. In the next few slides, these cases, I'll describe these cases with some interesting correlations. Next slide. I think Dr. Staples mentioned this in detail, so I'll be brief, but just wanted to refresh everyone on the definition for TBE as defined by the European Center for Disease Prevention and Control. Essentially, there are 2 classifications, either confirmed case or a probable case. There is no case definition for a possible case. And to meet the case definition for a confirmed case, an individual must meet the clinical criteria by having symptoms of inflammation of the CNS. As mentioned before, that includes meningitis, meningoencephalitis, encephalomyelitis, or encephaloradiculitis. And they have to have at least one lab finding listed here. The TBE-specific IgM and IgG antibodies in the blood, TBE-specific IgM antibodies in the CSF, or seroconversion, which is defined as a 4-fold increase in TBE-specific antibodies in paired serum samples, or detection of TBE viral nucleic acid in a clinical specimen, or isolation of the actual virus from a clinical specimen. The criteria are a little bit less stringent for a probable case. An individual must meet the same clinical criteria, but have symptoms to include the symptoms of CNS inflammation, but the lab finding of TBE-specific IgM antibodies in the serum sample. Next slide. So on to the known cases of TBE within the Department of Defense, again from 2006 to 2020. In all, there were 9 individuals who met the case definition for TBE. 5 individuals met the case definition for confirmed, and 4 met the case definition for probable. Next slide. All patients had neurological illness consistent with the case definition. Virtually all the individuals reported fever, and other symptoms variably included weakness, mental status changes, nausea, headache, vomiting, diarrhea, and neck stiffness. Many patients had sequelae lasting from days to over a year. For example, there were reports of decline in memory and difficulty concentrating for greater than a year, fatigue, attention concentration issues for 5 months, fatigue, headache, visual disturbances for 1 month, and reduced psychomotor function and headaches for 10 days. Next slide. Among the 9 cases, 1 occurred in 2012, and the remaining 8 cases have occurred since 2017. Next slide. As expected, virtually all the cases occurred during tick season, which, as Dr. Hills already mentioned, was between April and November. Next slide. The cases occurred exclusively in Germany, specifically the southernmost states of Baden-Württemberg and Bavaria, as you can see pictured here on the slide, or on the picture on the right. Next slide. When we looked at the cases by age, you can see that these cases involved a wide range, specifically individuals 2 to 47 years of age, and the median age being 33 years. Next slide. When looking at the cases by sex, 8 were male and 1 was female, very much mirroring what Dr. Staples mentioned in the civilian population. The one female was a child. Next slide. When we looked at the beneficiary status of the individuals, 6 were either service members or retired service members, and 3 were dependent children. Next slide. When looking at the individual's travel status, all cases of TBE occurred in residence or permanent party status. None of the individuals were in a temporary traveling status. Also, none of the cases had reported any receipt of Tbe vaccine. Next slide. This slide simply breaks down the case by occupation, and you can see that it was quite varied and did not isolate to one particular military specialty, such as an infantryman that you would expect to be more exposed to the tick because of their duty and doing more field training exercises and being outside more. Next slide. So in conclusion, tick-borne encephalitis has been documented in the DoD population living in endemic areas. TBE is a public health and forced health protection concern for U.S. service members and beneficiaries residing in or traveling to Europe. TBE immunization opportunities for DoD may be insufficient without an FDA-approved vaccine. Next slide. And that really concludes my brief, and I'm happy to entertain any questions.
Thank you very much for that presentation. Are there any questions from the voting members or liaisons? Seeing none, we'll move on to the next presentation. Thank you again. We're back to you, Dr. Hills, regarding summary of risks for TBE for U.S. travelers and laboratory workers and the next steps.
Thank you, Dr. Romero. And so I'm going to finish the Tbe vaccine session by providing a summary of the key issues from what we've discussed today. And these are going to inform Tbe vaccine recommendations. Firstly, in terms of the geographic locations where there is increased risk of infection, comprehensive data are frequently limited. Although the general area of Tbe virus transmission extends from Europe through to Japan, the virus typically occurs in focal locations, and precise transmission areas can be hard to define. Incidence is variable from country to country and in areas within countries. Transmission levels fluctuate from year to year, and overall there is a very low risk in urban areas. There is a clear seasonal risk, which occurs in the warmer months from April to November when ticks are active. There are very low numbers of TBE cases among US persons, with only 11 cases reported in US civilian travellers during the 21-year period from 2000 to 2020, and 9 cases among military personnel in the 15-year period from 2006 through 2020. While TBE occurs at low incidence among US travellers, the disease can have a high impact in terms of mortality and sequelae, although case fatality and sequelae rates vary depending on the infecting TBE virus subtype. With some subtypes, case fatality rates can reach 20% and sequelae rates can reach 80%. Finally, the key risk factor for infection is entering an environment where exposure to ticks can occur, with important tick habitats being in and on the edges of forests and in other areas where there is low-growing dense brush and low ground cover. Exposure to these environments can occur when travellers are involved in certain recreational activities, such as hiking, camping, fishing, cycling, bird watching, or foraging for mushrooms, berries, or flowers. Occupational exposure can occur for persons in occupations like forestry work or the military. Lastly, there is a risk for infection for laboratory workers working with TBE virus who can be exposed through the aerosol or other routes. While there have only been a small number of laboratory-acquired infections over time, the likelihood of disease among those with an exposure is high. The TBE vaccine work group will be keeping this epidemiologic information in mind as we draft vaccine recommendations. However, the next steps for the vaccine work group during the next 4 months are to review vaccine safety and immunogenicity information and related data as we prepare to present the ETR and grade to ACIP at the June ACIP meeting, with the intention of having ACIP vote on vaccine recommendations at the October ACIP meeting. With that in mind, the work group has prepared the Tbe Vaccine Policy question, which is, should Tbe vaccine be recommended for use in persons aged 1 year or older, travelling to or residing in Tbe risk areas, and in laboratory staff working with Tbe virus? Thank you very much, and I'm happy to take any questions.
Sorry, I lost my list again. It keeps popping up and down. Are there any questions from the work group members? I'm sorry, from the voting members or from the liaisons? Again, I'm not seeing any. We'll move on then. Thank you very much, Dr. Hills, for that presentation.
Thank you very much.
We have a break scheduled until 3:30. Do we have a break here? Yes. Dr. Cohen, do we want to break a little bit here? Okay, so we're going to break until 3. Yeah, at the top of the hour. Okay, very good. Thank you very much.